family. I'm one of 8 siblings, and my father just stopped practicing ear, nose, and throat surgery 2 years ago at the age of 88. So around our dinner table, the most interesting conversation had to do with the patients or the surgeries. And of course, my mother made it all happen, but her conversations about the Hadassah and the bowling score didn't get quite as much clout as my father's conversations. And so if you wanted to be heard at the dinner table, you kind of had to go to medical school. So there weren't that many options, and about 5 or 6 of us followed that direction. And I have a sister, geriatrician, a sister an epidemiologist, a brother an obstetrician. So, you know, it's sort of a crazy medical family, a lot of fun. I went to Smith College, which you didn't hear, and it was right after Gloria Steinem and Betty Friedan, and there weren't many women in medicine. I was one of 12 in my graduating medical school class, and now the classes are about 50% women. So it was still a bunch of kind of oddballs, kind of great oddballs, but oddballs nonetheless. And at Smith, it was just following Watson and Crick, who figured out that, you know, inherited traits were on strips of DNA that comprised genes that went from generation to generation. And the most exciting to me was this Jacob and Monod, who got the Nobel Prize for the operon theory. They actually figured out that these strips of DNA had little pieces in them that turned them off and on and regulated it. This system was all regulated. It's a brilliant, brilliant system. And I was fascinated. So it really wasn't hard to go into the sciences. I found it fascinating. It was like puzzles and people. And I said, if you like puzzles and you like people and you're willing to work hard, then medicine was a wonderful career and has been a wonderful career. And then how I got into gastroenterology, I used that line, life happens when you're making plans. So don't even go there. I mean, that's sort of a side story. And it didn't really matter. My gastroenterology professor said a good mind wraps itself around just about anything. And I think this was a good field for me. It had some amount of doing something, some amount of thinking, and whatever it was. It didn't really, it's been a good career. And things were moving along, and I would try to keep up with the medical literature and try to keep up with the gastroenterologic literature and try to keep my endoscopic skills going and try to raise a family and be a wife and a mother and, you know, all those things that take up your time. And then in 1994, I was about 43, and I just thought, well, God, if you can have a baby, you know. So my last baby, maybe many of you know, is Ellie. And Ellie came and didn't just progress. Ellie had so-called developmental delay. So now you're going to get my heart. That's where my heart got into medicine. So Ellie was a puzzle, a real puzzle. And I said, okay, it's a puzzle. Let's solve it, right? Let's fix it. And that's when I learned that you really just don't fix everything. That was like, you know, you don't understand everything and you don't fix everything. And sometimes you have to accept and you have to learn and you have to, and I went to every alternative practitioner. We've been acupunctured. We've been gluten-free, dairy-free. We've been up and down. I called us the medically disenfranchised. You know, I started to relate to the people who were the medically disenfranchised. We don't have a name for what you have. And then I realized we don't have a name for a whole lot. We don't know a whole lot. So what I learned being Ellie's mother about attitude is therapy. Use the strengths and build on the weakness. Everybody needs hope and a plan. These were things that were given to me through my search with her. They were given to me for me to use with my patients. Some things are straightforward. Many things are not straightforward. So that started to inform who I became as a physician. So when the person came into the office, yeah, some of them just want a colonoscopy and that's easy, or they just have some easy thing to fix, but many of them come with a history and with all kinds of issues, and you can't look at the gastroenterologic tract without looking at the person and looking at how they cope and looking at what their influences are, and then try and use that same kind of wisdom, attitude, positive, hope and a plan, all of those things, and try to create a plan and try to create an understanding. So I just thought the best talks I've been to are ones where you kind of know who's talking and you get a little personal and you don't just do mini medical school. And my husband keeps saying, don't digress. They don't want to hear about that. They don't want to hear. But I just, it came to me like today, you have to digress because that's really what's informed my practice. And it's why I don't have I'm 63, I have no even question of the burnout. I just feel like, I'm just getting it. I'm just getting it. The patients teach you, you teach the patients, you collaborate, you go to the literature, you try to bring them what you've got, and you try to make a plan together. And it has, so that really has informed my practice. And then, some other things have come up, and we'll get to them. But the other thing, it was a couple of years ago, and this woman was telling me a story, and she was talking about some difficulty swallowing. And I said, well, when did it start? Do you remember when you started having that feeling? And she said, yeah, it was, I had these 2 boys, and my son was diagnosed with lymphoma. It was a rough time. My husband lost his job. And I said, boy, that's a lot to swallow. And I didn't think I was making a pun. I didn't really think I was making a pun. I wasn't trying to take her problem lightly at all. But I started to think, it's a metaphor. The body kind of, if you listen, often the body speaks. And I've always, so now I have a yoga teacher who says the issues are in the tissues, and I sort of, but it's about knowing who are you talking to across that desk, what are the issues and how do they manifest in the illness, and how can we use all our resources, Eastern, Western, whatever, and try to heal. And I find this community so exciting to work in because smart people go that way. Smart people don't stop with Western medicine. Smart people are looking at all avenues. Smart people who feel medically disenfranchised don't stop there. They keep looking. They go inside and outside the box. They put gizmos on their legs to deliver electric shocks, right? And it's all. And the other thing you find as you're in this business long enough is that the so-called alternative practitioners, and we fault them for doing things that are not. What do we call it? Controlled, double-blind controlled trials, evidence-based. So we give them all this flack because they're not evidence-based, double-blind controlled trials, and they do stuff, right? And so, and medicine, Western medicine, is supposed to be all double-blind controlled trials before you do anything, right? And you see when you've been in it long enough where that alternative starts to creeping into the Western medical literature, and so you have to, of course, be careful, and they're people who will take advantage of you, but most well-meaning people, you just have to figure out for yourself. You have to stick with it and explore lots of different avenues. So going along with the before I get to the bulk of this talk, I went to the Google and I Googled agita. I really wanted to know what's the definition of agita, because it gets to this whole thing, the gut as the metaphor, right? So we all know all those things, gut feeling, tough to swallow, pit in my stomach, can't digest that, all of these sayings, and it's just so interesting. And this is about the gut as the second brain. So we're going to talk about the gut, and we're going to talk about anatomy and physiology, but you have to, what I want you to understand behind all of this is there is a very elaborate nervous system that is, there are pacemakers, there are nerves telling everything, what to do, when to do it, and that is a second brain, and that's something that is, I just saw last week, there's a new chair in the GI division at Columbia University of neurogastroenterology. So again, this stuff that the alternative practitioners were talking about 10, 20 years ago, now they're trying to study the brain that's in the gut. and try to see, can we understand it better? Can we manipulate it? And the other thing it's where all these, we divided, the information explosion. There was too much information, so we divided the body into all of these pieces. All of you know. Oh, I go to my ENT, I go to my GI, I go to my rheumatologist. You know, we divided it into all these pieces, and people don't talk to each other, but it's just really one body, and it's more these systems are more the same than they are different. So again, the gastroenterology is the next wave of trying to bring these things together and see where they come together. I remember hearing somebody say, if you want to understand ulcerative colitis, read the rheumatoid arthritis literature from 10 years ago. So it's really just the same disease that manifests in a different organ system. So again, when you think you know so much, you really just your mind just keeps getting open. So the agita. I ain't a healthy gut. My stomach can't take this agita. Anxiety, stress, or aggravation. The Urban Dictionary has two definitions. One is heartburn or gastric distress, and two is giving you more aggravation than you can stand. So that's a very good one. She took a deep breath to dispel her agita as she stepped on the stage. Origin, Italian dialect, pronunciation of acido, which is acid. And this one I liked. American politics has also too frequently become an all-or-nothing proposition, making the USA the United States of agita. So the fact that people come to me with their agita means I have got to be more than just a gastroenterologist, and I enjoy that, which those of you who are my patients know. So now we're going to go through sort of the MiniMed aspect of this, and my colleague Henry Beecher, who many of you may know, helped put some of these slides together, so I have to thank him. But we're going to talk about the anatomy of the gastrointestinal system, and we're going to divide it up like it's obviously divided into upper intestinal diseases, small intestinal diseases, colonic diseases, pancreatic diseases, liver and biliary tract diseases, what some of the things we know and what are some of the more challenging things. And so this is really what we're talking about. We're talking about these organs, the esophagus or the swallowing tube. Again, the whole gut is basically a tube with some buds off of it, but the allusion again to that nervous system, it's a smart tube. So this esophagus, it would just blow your mind. It's a tube that's cinched at both ends, and as you start the swallow, the upper cinch knows to relax to allow the food in, and then tightens up again so that the food doesn't spill into your airway. And then the peristalsis starts, and it has to be just so that the food gets down to the tight little lower esophageal sphincter that will then open up and dump the food. So again, if you just looked at it, you'd never know any of this stuff was going on or going awry. But if it doesn't work right, there's a little hell to pay. So the esophagus, the stomach, and we'll talk about the function of all of these organs. Esophagus, stomach, small intestine, gallbladder, liver, and pancreas, buds off the upper digestive tract, 20 feet of small intestine. So this is a huge factory of absorption and digestion, 20 feet all crumpled around, curled around in your abdomen. And then the colon, the large intestine, which is stretched out probably 4 or 5 feet and occupies the perimeter of your abdominal cavity. So we'll get into this a little bit more. The esophagus, as I said, the swallowing tube, and then we'll talk a little bit about what can go wrong. And you see in this, you see in this picture that not only do you have this little muscle band that's under neural control to stay tight so that your acid that's produced here doesn't get up into your esophagus, but you've got the leaves of the diaphragm, this major muscle that surrounds this lower esophageal sphincter. All of this is protection against the reflux of gastric contents. The stomach itself, which you'll see here, is basically analogized it to a cuisine art. It's a it's a 3 layers of muscle. It's thick muscle. It mushes and gushes. It's got a pacemaker in there. It's got all this motility, and it's also a secretory organ where these cells in these pits secrete acid to digest food, secrete pepsin to break down bonds between amino acids, the muscle layers, and then the pylorus, which is the next sphincter here, the pylorus, which is, I think it's Greek for gatekeeper. So the food has to be a certain particle size. I think it's about like 4 millimeters before it can get through the pylorus. So, it's fascinating. It's just so intelligent, this whole thing. So, thinking about willy-nilly messing with it, you really need to mess with it, right? Thinking about surgery, thinking about medication. You don't get away scot-free with any of that, right? Block acid, something happens. Somebody who was a pharmacologist once said to me, any medication that blocks a normal biologic system will have a negative side effect. The only medication that may not have a negative side effect is something that potentiates, sort of helps something along. So if you think about, all of these systems as so intelligent, if you block something, somebody's going to speak up. So surprise, there's a side effect, So anyway, this is something that we're dealing with all the time. Okay, and then we move on to this concept of endoscopy, and this is our window into the upper digestive tract. What is it? It's the placement of a firm tube with a computer chip and light bundles that gets projected onto a screen, and that's called an upper endoscope or a esophagogastroscope. And when do we look into people's stomachs? Well, you're very happy if we look into your stomach if you come in bleeding from your stomach, because there's something we can do about that. There are channels through these scopes, and we can put instruments, and we can stop bleeding, and we can take biopsies, and we can remove polyps. And I was going to leave this for new on the horizon, but there are the sort of cutting edge of minimally invasive surgery is something called NOTES, which is using the natural orifice, use the mouth to pass a piece of equipment, and then through the stomach, and then move the intestine aside and remove the appendix. I mean, how cool would that be, right? Just take it right out through the mouth. So these things are going on, natural orifice surgery. So this scope is part of the window into the digestive tract. We also have endoscopic ultrasound, and so what we have is an ultrasound probe around the tip of that scope. So not only can you see the wall of the bowel, but you can see through the wall, and you can see the adjacent organs, and you can use the stomach to access the esophagus to access lymph nodes in the chest. You can use the stomach to access a pancreatic lesion, to drain a pancreatic cyst. So the technology is sort of fascinating, and that's the upper scope. Most people who have upper endoscopy here in Fairfield County are having it because of chronic acid reflux. And it probably, and we'll kind of get to that. That will be a topic that we'll talk to. In order to have the procedure, you come into the endoscopy unit having not eaten for 5 hours, let's say, and then you're put to sleep, pass the scope while you're sleeping, and the whole thing takes about 10 minutes. We also use this to get biopsies of the small intestine, biopsies of the stomach, and again, to look for this not gastroesophageal reflux, because gastroesophageal reflux happens, and there would be typically, most people reflux multiple times a day. But if the reflux is significant and long-standing and needs treatment with medication, then people are concerned about Barrett's esophagus. A young person, do I have some kind of an anatomic disturbance that's making it so I reflux? Is there something you can do besides give medication? Is there some other explanation for my esophageal symptom? And that's these, eosinophilic esophagitis. And then we talk about alarm symptoms. So alarm symptoms are weight loss, blood loss, trouble swallowing. That would be red flag. Red flag, okay, something bad's going on in there, we got to take a look. Just sort of stable acid reflux, our rule of thumb is do an endoscopy once and just check out the anatomy and check out yay or nay on the Barrett's esophagus, which we'll talk about. And then this concept of motor and sensory issues, which I put in here, that is really just like the nervous system altogether, more of a black box. It's just difficult to diagnose, it's difficult to treat. If somebody doesn't have good peristalsis, if somebody doesn't have a sphincter that opens, and so that concept that disease can be structural or functional is a big one in our work. So you can have an actual blockage, you could have a mass or a stricture at the bottom of your esophagus, or you could, and that's a structural thing, and we'll do something structural about it, we'll open it up. Or you could have something functional where the muscle doesn't release, or the peristalsis doesn't happen because I don't have my good neurons in my esophageal wall. It's a much more difficult whole area. So we have ways to look at it. We do motility studies, we do pH probes, we have lots of ways to look at it. We don't have great treatment for these, for functional disorders. That's that whole neuro, gastro, that's when the nerves are not working, there's so many influences, and we have to look at everything, and those are really more challenging. And then maybe you would say more interesting, interesting for me. Okay, so we talked about GERD, gastroesophageal reflux, and most people with gastroesophageal reflux will have an esophagus that looks beautiful, and you'll see nothing. And rarely you'll see what this would be like complicated GERD. So this is complicated. I don't know if you can appreciate, but down there is where the diaphragm is. So that this amount of tissue is all in the chest, a hiatal hernia. So you've lost one of your mechanisms for keeping the acid out of your esophagus. The acid has come up. It's created a kind of stricture here. This is a peptic stricture from acid. The acid has eroded the lining of the esophagus here. So this is all ulceration. I remember when I first started, I didn't know, what does an ulcer look like? So this is ulceration. This is white blood cells and inflammation eroding the lining of the tissue. And you could imagine that if that inflammation goes deep, you can hit blood vessels and you can bleed, it can hurt, and that's, okay. So this is a complicated reflux. That's ulceration. Symptoms of GERD, typical symptoms are just what you know of as heartburn. Atypical, we have people come in with hoarseness, with cough, with throat clearing, and that can be a sort of atypical. We talked about the red flags. We diagnose by looking, and then all of those functional studies, motility studies. The cause of acid reflux. Well, so here we've lost our good diaphragm, so that predisposed us to this reflux. Other things that contribute to reflux, lifestyle, agita, aggravation. So how does aggravation cause reflux? What do you think? Everybody always talked about aggravation causing reflux and causing ulcers, and then they said, no, it's not, it's H. pylori, it's anti-inflammatories, it's not aggravation. But I think that we're going to get to this with this neurogastro business, that with aggravation, you get into a situation where you have an overstimulated sympathetic nervous system. You know, that's got to be. And the sympathetic nervous system is preparing you for fight or flight, right? And when you're in fight or flight mode, you're not supposed to be eating or digesting. Your blood goes to your muscles to run, to your brain to think. You know, it's diverted from your gut. So everybody knows when you're in a tense situation, you don't feel like eating. And I think that's the agita. And we'll get into I think we're going to start understanding more about acute stress and chronic stress, right? They talk about this chronic fatigue and fibromyalgia. I mean, I'm off of my turf here, but I think this whole thing of acute and chronic stress has effects on every system, and I think it has effects on gut motility. So that's why, you know, I tell many people to meditate and do yoga, and people say, oh, yeah, Sarah. Oh, Sarah says do yoga. but it's about this concept of balancing the nervous systems, which I can't tell you I know that much about, but you know it when you see it. You know it when you see somebody who is out of balance. And that whole balance thing that comes before the illness thing, you know, a lot of us are living in that world of trying to maintain balance in order to keep from getting significantly ill. And illness, Western medicine is pretty good once you're ill. The balance part is where we have to rely on ourselves so much more, and where maybe there are things in Eastern medicine and maybe there are things in meditation and yoga better for that balanced life to keep you on this side of the illness side. That's sort of my prejudice and what I've seen through my years. So what is Barrett's esophagus? Well, if that lower esophagus is exposed to acid for a significant period of time, in its intelligence, it will try to do something. What will it do? It will change its lining to a cell type that is more acid resistant. That's intelligent. So it becomes populated with this stuff, and this stuff has a name, specialized columnar epithelium, and it is more acid resistant, but it has a tendency to, it's in the wrong place in the body, it has a tendency to that line, inflammation, dysplasia, metaplasia, neoplasia. So it's the concept of neoplasia. When you have inflammation, you have cell turnover. When you have cell turnover, that DNA can make mistakes. When you make mistakes, you start going towards cancer. So you have time, but you have this, any chronic inflammatory condition can be a precursor, which is why sun damage can be a precursor to skin cancer, right? You turn over. That's why damage the lungs with cigarette smoke, and you have to keep making new cells. You're making new cells, you're going to make mistakes. So that's, it's a very simplistic explanation for that line from inflammation and toxins in the environment to metaplasia, dysplasia. So even though the body tries to be very intelligent, that's, you're trying to keep that inflammation thing down. So this is Barrett's esophagus. And when we find this, we know this is has a higher risk of neoplasia, and we're going to ask this person to come back at some intervals to keep biopsying and checking. We're going to try to keep the acid out of that area with the acid blockers. So here we're willing to take the risk benefit of the acid blockers because we're going to try to keep the acid away from that piece of the esophagus. We're going to do biopsies to see, are we moving towards that dysplasia? Are we moving towards that neoplasia? Because removing an esophagus is a big, bad surgery. You really don't want to have that surgery. So what's come up in the last couple of years is something called radiofrequency ablation, where if you find that it's really moving in that direction, you can cook it, you can heat it up, and you can get it back to that old squamous mucosa. So, none of this is so nice and easy, but it can be done. So we follow these people. It's called surveillance, okay? That's called surveillance. We're keeping an eye on an at-risk population. Okay, so the hiatal hernia we talked about is a hiatal hernia is pretty common. You think about, especially as people gain weight, and that diaphragm, which is just 2 leaves of muscle, is going to pull apart, and so all of a sudden that nice little sphincter that was surrounded by muscle can slide up into the chest, and that's called a sliding hiatal hernia, which you see right there, sliding hiatal hernia, which you can have that and it can be no big deal, or it can predispose to reflux. It can we see the little old people with a lot of the stomach up into the chest, and they could be well in every other way, but they could have recurrent aspiration. They could be getting pneumonia frequently from a stomach sitting in here and then getting food and fluid into the lungs. So it's the kind of thing that I was thinking about this today, that the obesity epidemic spawned a whole subspecialty of bariatrics. Bariatric surgery for obesity got all these people trained in using a laparoscope and doing stuff around the diaphragm. And the side benefit of that is these bariatric surgeons will love to go in there through your belly button and pull your hiatal hernia down into your abdomen and tack it down, if you're in time to do that. So we do have that capability if you're getting in trouble. I've had people with their colon up in their chest, and then it gets squeezed up in there and they get colitis in their chest. I mean, because if that opening is big and if those organs are floppy, you can get anything up into your chest. So tightening up the diaphragm and pushing stuff down, that's the realm of laparoscopic surgeons, and the skills are getting better and better because of the bariatrics. So it's just very interesting time in medicine. This is the diagnosis du jour, eosinophilic esophagitis, and I have to speed up. How long do we have here? Maria? 7:30 or 8? Oh, okay. So this thing, which is like the diagnosis du jour, eosinophilic esophagitis. It's very interesting. I mean, we didn't know about it 10 or 15 years ago, and people would come into the emergency room, especially every Thanksgiving, with food stuck in the esophagus, and they can't swallow, and they can't swallow their secretions, and so it turns out that this is it's kind of like an allergic disease. These people tend to be, we call atopic, hay fever, asthma, that type of predisposition, and they get inflammation in the wall of the esophagus with those allergic cells, and the esophagus is less pliable, and it's a stiffer esophagus. And when you look down with the scope, so anybody who gets food bolus impaction, we wind up scoping them to sort of see what is the underlying reason. Why did food get stuck? So if they've got this look with these ridges, and then we take biopsies, and we're looking for those allergic cells in the wall, and then we make the diagnosis of eosinophilic esophagitis, and then we have to figure out, in children, they've found that elimination diets work very well. Now, elimination diets are really challenging to get rid of 5 major, dairy, wheat, soy, nuts, but they work in adults as well. The other thing is we use the acid blockers, work in about 50% of these people. And then another thing we use is steroids that, like if you have asthma, you inhale the steroids to get them into your lungs, so you don't have to take systemic steroids. And for this, you could actually swallow that, instead of inhaling the steroids, you depress the puffer, and then you got to swallow it. Then you got to get it to coat the esophagus. There are others. They're sort of they're slurries and things like that with steroids. But it's a way to get steroids to the spot and not get too many steroid side effects. What was somebody going to say? Okay. All right. So that's eosinophilic esophagitis, and it's a very common cause of food getting stuck. And we spend quite a bit of time with people with motility disorders or eosinophilic esophagitis, reminding people the food bolus impactions happen very often when you're out, you're animated, you're drinking, you're eating, and you're not paying attention, and you're not chewing well. So we do a lot telling people when you're out, I tell them, order the shepherd's pie. Definitely do not order the tandoori chicken. That's like the driest thing I can imagine. But, make sure your choppers fit well. Don't take chewing for granted. Don't try to do too much. It's a lot to organize your pharyngeal muscles, your teeth, your tongue. You take all this stuff for granted. Just wait, it doesn't work. Okay, so esophageal cancer, I don't think we're going to spend too much time. There are two types. One is going down in the population, thank God. That's called squamous cell, and that's the cancer from the upper 2/3 of the esophagus. That's linked to smoking and drinking, and that's going down. We're seeing less of that, and we're seeing more of this adenocarcinoma that goes along with this Barrett's esophagus and reflux and Mickey's agita. I mean, I don't know, but it's a sequela of Barrett's esophagus, the adenocarcinoma of the gastrooesophageal junction, and so that's what we're really trying to do this surveillance and try to do something about it. And it's also worse with cigarette smoking, and we are, we make these diagnoses. These are, and then these patients go to our oncologic colleagues, and there's still quite a bit. There's always hope and a plan. It's not a good diagnosis, but there's always hope and a plan, and many people still do well. So it's not a death sentence anymore. So we'll kind of cruise a little bit. The stomach. Helicobacter pylori, gastric ulcer, gastric cancer, and then non-ulcer dyspepsia. My stomach hurts and I don't see anything. It's better with PPI, better with Prilosec, better with Nexium. Okay, how long do we stay on that? Well, that's all the deliberation that we do very often. Weigh the risks and the benefits. Take as little medication as you possibly can to get rid of the symptoms. Understand that when you're taking an acid blocker, there's a hormone called gastrin that's saying, hey, where's my acid? Where's my acid? And it's going up. That's what I told you. Don't get away with blocking. There's a hormone that's waiting for more acid. So as soon as you take that PPI away, you're going to get hit and you're going to say, oh, damn, I really need that PPI. But no, if you were to just taper it and give it some time, the gastrin will go down in your system and you'll sort of equilibrate. So it's something people don't say, oh, you go to the drugstore, they say, oh, here's a 14-day pack of Prevacid. Well, I don't think that's such a great idea. Again, you need to think about what you're doing. 14-day, because then on the 15th day, the gastrin says, woohoo, the acid goes crazy, and you say, let's go get another 14 days, So I'm very involved in trying to keep people on the least amount of medication, taper it, so that you don't wind up in those situations. And then this concept of motility disorder, we'll get back to the agita. We have this, and people with nausea, people with, the food is sitting, the food is not moving. This is a really difficult thing because we don't have good medication for motility. That medication has a lot of side effects. So we try to use a lot of behavioral things like graze. That would be the normal thing you would do if the food felt like it was just sitting there, but maybe that's a problem, a functional problem with the nervous system. And then I have to tell you, there is this entity called CVS, and I bring this up because it's just so fascinating, cyclic vomiting syndrome. I mean, it's horrible, but it seems to be linked to migraine headaches. So here you go. Something that happens out of the blue, it may have a trigger, it's violent, and then it's over, and you see nothing. Well, that sounds kind of like a migraine. And they wind up in a gastroenterologist office. So I looked up in my book about 10 years ago or something, looked up in my book, what is this? And they said, for cyclic vomiting, call this number. This is in the GI textbook. So I call the number. The number is the Cyclic Vomiting Society in someplace in the Midwest. It's a mother, of course, a mother of a child with the disease. What else is it? And so I said, I'm interested in the illness. Well, next thing I know, I'm on the list of specialists who are experts in it, right? so because because these people are the medically disenfranchised. Nobody knows what this thing is. But it seems like, so now there's a literature on it, and it seems like more on families with migraines, and you try to look for the triggers, and you try not to do all kinds of elaborate testing. You know, if you didn't get it, you'd say, oh my God, but something that was really serious like that wouldn't be intermittent. You wouldn't be all better after. So you have to use a lot of judgment when you're seeking, when you, I mean, because fear comes into this, right? Fear interferes with judgment. So you have to back away from the fear and look at the pattern and kind of try to put it together and see what, you know, and then see, who is this person? What's the family history? What's in that family? What do people have in your family? You know, how do they express illness? So anyway, that's one of the interesting motility disorders. And then the whole spectrum behind CVS would be anxiety and upper GI dysmotility, or just intermittent upper GI dysmotility. Maybe that's a mild headache of the gut. So here's just some pictures: gastritis, inflammation of the stomach. We can see it with this bacteria called Helicobacter pylori. We can see it with Advil, Aleve, Nuprin. None of those things are free. You know, they all can cause GI bleeding. They all can cause gastritis. I know they're fabulous drugs. Excedrin migraine is a great drug. You just have to, you know, use it mindfully and try everything else. Try, you know, make sure you're not hydrated. That's giving you a headache, and you could have a couple more glasses of water. Make sure you're not too stressed, giving you a headache. You know. So don't. We get a lot of business from these non-steroidal anti-inflammatories. There are other causes, and then the symptoms. So the Helicobacter pylori I think I was in my training with early 80s. It was discovered by an Australian as a major cause of gastritis and peptic ulcer disease, and that was big headlines. Ulcer is infectious disease. Before that, it was agita and treat with milk, right? And all of a sudden, it's look for Helicobacter pylori and treat with antibiotics, or look for non-steroidal anti-inflammatories and get rid of them. And then the combination is bad. So we look for the Helicobacter. We try to eradicate it. There are, it can be a cause of something called malt lymphoma, the Helicobacter. Another reason why if we see it, we get rid of it. Even though, an interesting fact, which is when your stomach has this infection and you have inflammation from the Helicobacter, your acid production is not so great because it's being suppressed. So you don't feel so well, but all of a sudden we treat your Helicobacter pylori and you say, oh my God, now I really don't feel well. And that's because your stomach just got healthy. So now we got to get things going in the right direction, you know, because acid is great as long as it goes in the right direction. Okay, so just if you understand what it is you're doing, you'll understand how these treatments work. A peptic ulcer, again, it looks like, so this is an ulcer. Could be from H. pylori, it could be from non-steroidal anti-inflammatory, and if that inflammatory cells burrow deep, they can blow a hole right through your stomach, or they can go right into a major vessel and cause bleeding. And so that's what we see when we see ulcer bleeding. We look for, we call it stigmata of recent hemorrhage. Is there a clot on that ulcer? Is there a vessel you can see? Or is that, and that will tell you what is the risk of that ulcer continuing to bleed. And based on that, we make a decision of how to treat the ulcer. So, you know, this is why we're on call to the emergency room, and this is what we get called in for, is bleeds. And then we have to decide, okay, who to treat, how long to treat, based on the complication. But this is, and you know, this looks like a canker sore in your mouth. Right? That's the analogy. That's what everybody's seen the canker sore in your mouth, and that's exactly what an ulcer looks like. You know, but the size and the depth all determine how serious the thing is. Gastric cancer is a more awful looking, and so this is a gastric cancer, and again, treated with surgery, treated with chemotherapy, with you know, not a very good prognosis. Still, it's not a frequently cured. Small intestine is so interesting now because it hasn't gotten a lot of attention in large part because it's been really hard to examine. So these things called enteroscopes, it would take, if you really needed to see somebody's small intestine, you would put a scoping, and then they'd have to roll all day to get the thing to pass all the way through the 20 feet. And then you could only see when you're taking it out, and you can't do anything. So it's been, and we're getting better at accessing the small intestine with double balloons that work sort of with a suction system. But it's been a difficult place to see. We can see the first part of the small intestine, the duodenum, with a gastroscope, and this is where most of the celiac disease happens, and we'll talk a little bit about celiac disease. And we can see the last part, called the ileum, by going backwards after a colonoscopy. We can go in there, and that's where a lot of Crohn's disease happens. So when we're looking for those things, we try to access the small intestine. Otherwise, we're getting MRIs, or using radiology to look at the small intestine. Yeah, Harry? The camera, yeah. So we do have a small bowel capsule, and that's really, and again, diagnostic, not therapeutic, right? So we have this capsule that you can swallow, and it just bobs through your gut, and it's taking pictures all the time, and then you just pass it, and you're carrying a little pocket, a little computer that's recording the images and recording where it is on your body, and we try to put all this together and see where is the disease, and then if we find it and we have a little idea of where it might be, then we can send you to somebody who can do that double balloon, or maybe even send you to a laparoscopic surgery to try to isolate that. Thankfully, there's not much cancer of the small bowel. It's unusual. It does happen. It's unusual. So we're not into, stuff doesn't hide in the small bowel so much because things are moving so fast. So there's not that much chance for things to hide. But it's interesting. And small bowel up close, it's just this tremendous absorptive surface area. There are 12 liters of fluid that enter the small intestine between oral secretions, stomach, esophagus, liver, gallbladder, pancreas. 12 liters come into the duodenum. The duodenum absorbs all but 1 liter. So 1 liter makes it to the ileocecal valve, and then your colon is responsible for turning that 1 liter into something reasonable for your toilet bowl. Okay? So that's a big job of about 10 or 11 liters a day of absorbing, digesting, figuring out what to do with. And the other thing, which is hot, is the microbiome. So the small intestine houses more 10 times as many cells that are in your entire body are bacteria that line the small intestine. And those bacteria don't just live there. They are involved in programming your immune system. They are active, and so messing with them, again, with antibiotics, with radiation, with chemotherapy, it's a really challenging situation, and we all know about C. diff and the microbiome and the gut-brain, and people on gluten-free, they're probably doing something to starve their microbiome, and that makes them feel better. And this is a real new avenue of interest, and it's going to be how that, and I've always thought that immune system, those cells have memory, and the gut programs the immune system, tells you what's like and what's foreign, and the brain and the gut, and the brain and the immune system are the two kinds of cells with memory. So, this is all going to come out. I'm just sitting with bated breath to watch all this research. It's so fascinating, and we'll figure out that you are what you eat. That whole thing. It does matter. All of that stuff. That brain food. All of us try to figure it out for ourselves. But this is really fascinating. So we talked a little bit about celiac disease, and celiac disease goes in the category of the autoimmune diseases. So it's more related to rheumatoid arthritis and psoriatic arthritis and autoimmune hepatitis, and juvenile diabetes. These are all diseases where some foreign invader comes in and the body mistakes it for its own. Hashimoto's thyroiditis, and the body starts an attack that started out against that invader and then winds up attacking itself. So in diabetes, it's attacking the pancreas, and in thyroiditis, it's attacking the thyroid. And in celiac disease, wheat is the culprit, and wheat triggers an immune reaction against some enzymes in the small bowel lining, and the small bowel becomes a site of inflammation. And so this person with this celiac disease, let's go and we'll see, can have GI symptoms or no GI symptoms. They can just have anemia. They're not absorbing their iron because their small bowel's inflamed. They can just have osteoporosis because they're not absorbing their calcium, vitamin D. They can have neurologic symptoms. It's really multi-system disease. You know, when we first understood about celiac, we thought it was a GI disease of malabsorption because long-standing celiac will eventuate in malabsorption, and the people will look like kwashiorkor, you know. But earlier on, we see people with all of these things, the abnormal liver tests and infertility, so it's part of the workup for infertility. Now looking for celiac disease is part of the workup for osteoporosis, failure to thrive in a youngster. So this is an interesting disease that we get involved in because we can access that small bowel with our upper scope, and we kind of, but it's, again, it's an autoimmune disease. Interesting. All right, so the large bowel, which is, you know, the workhorse, it just, what it does, absorb the fluid that gets delivered to it and turn it into a stool and deliver the stool in at a time and a place that's reasonable, right? That makes you different from the animal kingdom or whatever. And so we're looking at this colon all the time because colonoscopy, you know, because colon cancer is common. It's in women who don't smoke, it's second after breast cancer, half as common as breast cancer. Breast cancer is 1 in 8, colon cancer is 1 in 16. In men who don't smoke, it's second to prostate cancer. We know that colon cancer, for the most part, comes from polyps, and if we can find the polyps and remove them, we can decrease the risk of colon cancer. So we use our scopes to look through the bowel and find these polyps and remove them, and that's mainly what we're doing colonoscopy for. We may also be doing it to evaluate inflammatory bowel disease, so some other things, rectal bleeding, you know, so there are other indications besides colon cancer screening, but colon cancer screening is the bulk of the reason we do colonoscopy. So these are some of the things we see, and I'm going to kind of go through. So this is what a polyp looks like. Usually it's going to be asymptomatic. You go in there, you see it, the bowel is clean, you put a little wire through your scope, you make a little lasso, you burn that little stalk, you put a little suction on the scope, and the thing comes into a little trap, and you send it to the pathologist, and you've taken out the polyp, and it's pretty, you know, it's a pretty good test. Diagnostic and therapeutic. It does have a risk, but it's a relatively low risk. And the risk of, what? Nothing. Okay. Yeah, so there's some thought that maybe we can prevent these with using nonsteroidal anti-inflammatories or aspirin or calcium. They do tend to run in families, but not always. And this, we all think a high-fiber diet is going to help us, and this is what we're trying to avoid. We're trying to avoid a colon cancer, and sometimes we find a colon cancer. You know, I had one last week in a 50-year-old woman, you know, who really had no symptoms, and you know, the thing is, we find it early. You know, if you have no symptoms, we typically find it early. It's amenable to surgery. Again, if you find it early, it hasn't spread. But you know, chemotherapy, we're doing much better. It's still not a, you know, it's still not a good thing, and it's still better to get your periodic colonoscopy. And what is periodic? This is all up for grabs. You know, in other countries, they're not doing screening colonoscopies. You know, in this country, we're doing screening colonoscopies, and the insurance companies are trying to limit how many we do. So we're going to just try to play it out. You try to get your screening colonoscopy. You try to get your baseline. You look at your family. What are people in my family? You know, certainly if you have a family history of colon cancer or early colon cancer, it's still indicated to get a colonoscopy every 5 years. If you have no family history and your baseline colonoscopy is negative, we're trying to stretch it out to 10 years, and we'll see how that all shakes out. We figure we're going to probably find some things. Now, one thing we do have going for us, I have to make a little plug. I'm not much of a, you know, I don't make many plugs, but we have these new scopes in the Tully Center. So we have just made a major investment, and we have these scopes that are seeing 270 degrees. So we're seeing all the side walls of the bowel. We're seeing crevices that we never saw before. So we said it was a 95% test. We said there are interval cancers. When you see an interval cancer, something that pops up between colonoscopies, you say, did I miss it or did that grow? You know, and of course, always you feel, oh my God, did I miss that? You know, but so we've got these new scopes. We're looking at 3 screens while we're scoping you, and we're seeing things that I think we would have missed before. And that studies have shown we're going to pick up another, you know, another big chunk of polyps. And I think I've even seen a cancer in the last couple of weeks that might have been really difficult to see. So this is, I think we're the first place in Connecticut to have these. You know, it's not all upside. I wound up with, I called it endo thumb because the scopes are not stiff. And so you're, so I wound up bleeding into my thumb but I've sort of changed my way of scoping, and I'm trying to figure it out. I think the benefit, you know, we're going to adapt to this because it's really so beneficial to be able to get this greater visibility, you know. So that's what we have. Diverticular disease, super, super common, especially in this Western societies, and you get little outpouchings of the bowel wall, and about 50% of people over the age of 60 or 70 will have these, and this is not a cause for concern. They have looked at people, so 20,000 people over 20 years, and if you just have diverticulosis, the presence of the pockets, the incidence of getting in trouble with those pockets is like 4% over 20 years. So just the presence of those pockets doesn't do anything. Now, on the other hand, if you've got diverticulitis, which is inflammation of those pockets, and you can get abscess formation, you can get fistula, they can burrow into your bladder or you know, it can be a big mess. You know, then we have patients hospitalized. It's a very common, so hospitalize them, try to cool it down with antibiotics. You know, don't have to, many people can be treated as an outpatient with antibiotics. First thing, you get a bellyache, stop eating. It's like, should be intuitive, you know, unless except for those of us whose mother always said, eat, you'll feel better, you know, but that does not apply to a bellyache, okay? So the first thing you do is you stop eating, you rest the bowel, okay? And that's, so you can, you know, often things will get better when you rest the bowel. You just rest the bowel. But if it doesn't get better, or especially if you get a fever, the bellyache persists, then you've got diverticulitis, and we've got to figure out how to treat you. And then, you know, whether or not you wind up getting surgery for diverticulitis really has to do with how complicated is it, or how much is it interfering with your life, making it, you can't live your life because you're frequently on antibiotics, or you're traveling, you can't afford this. And so at least we're doing better with the laparoscope. So if you get it to calm down, maybe you can have a kind of minimal surgery. But it does. It's typically in the sigmoid colon, the lower part of the bowel, so it gets down low. We don't like anything that's down low because we don't want anything to interfere with the defecatory mechanism. You like that? Right? Because if it interferes with the defecatory mechanism, you know, that is not good. Okay. So inflammatory bowel disease, again, we take care of a lot of patients with Crohn's disease and ulcerative colitis, and this is rheumatoid arthritis of the bowel. You know, this is an abnormal immune reaction. There's a genetic predisposition. It has something to do with the gut bacteria. You can't make a model for it in mice who don't have gut bacteria. So in a sterile-free environment, you can't make this colitis happen. So they're trying to manipulate the gut flora, trying to manipulate the immune reaction. That's what we're doing. It's a really, to me, this is fascinating because this is a disease of young people. It interferes with their trying to live a normal life, have children, you know, they're going through their lives. So it's quite riveting to me to help young people with these kinds of diseases to try to minimize their symptomatology and allow them to go through and have children and have, you know, and do all of that, do what they want to do in life. But it can be quite devastating. But you're seeing all the ads, Humira, you're seeing it on TV, right? So all these anti-inflammatories that are, and this is all about, this is sort of a revolution in medicine, creating antibodies against little parts of the immune system that are active here. These drugs are miraculous. The problem is they're incredibly expensive to society. You know, they're incredibly expensive to everybody. But that old way of giving a steroid, which was a blanket immune suppressant with horrible side effects, the cost of that was much greater. The cost in hip fractures, the cost in cataracts, atherosclerotic disease, the side effects of steroids. So at least we're trying to be smart and get down to where, you know, as tight as you can to where that immune injury is. So we've got a bustling research and development in the drug companies developing these small molecules, antibodies. They call them biologics. And we have people, when the guy first came to talk to us, it was about 15 years ago, and he said, this is the greatest thing since sliced bread, because it may sound kind of gross, but you have a young person where a tunnel forms between the rectum and the buttocks, and they're pouring stool out the butt. You know, it's devastating. And we saw a lot of that. And with these drugs, we don't see it anymore. Tunnels between the rectum and the vagina, tunnels out the abdominal wall. That's Crohn's disease. Bad, when Crohn's disease is bad. So these drugs have revolutionized those diseases. So that's a real positive. And that's, and hemorrhoids. So hemorrhoids, what are they? Well, hemorrhoids are part of a vascular cushion of the rectum. And with straining and bearing down and having children, they can become engorged and they can prolapse and they can wreak havoc. And managing them is the best thing you can do. If they're bleeding, they're typically internal hemorrhoids, and they can be rubber banded, and that's not such a big deal. When they're on the outside, they involve the skin. It is a big deal because that skin is highly sensitive. So surgery on that skin. So we recommend you live with it unless you really can't manage, you can't get clean, you can't stop bleeding, you know, and then we recommend hemorrhoid surgery. But most colorectal surgeons will try to manage, and more than 9 out of 10 people, they'll manage them just by managing the bowel habit or managing the patterns. Okay, and then we get into this realm of functional disease. So functional disease, things are not moving the way they should. And if it's too slow, it's constipation. And, you know, if you, I guess I didn't say, what is a normal bowel habit? So if you take 100 people, I think 100 postal workers, I don't know if those are normal people, but that's what was studied. That's what was studied, but if you take 100 people and you say, what's your bowel pattern? It's anywhere from 3 times a day to 3 times a week. So you say to the patient, you don't have to have a bowel movement every day. You have to be comfortable. 3 times a day to 3 times a week, as long as you're comfortable. Given that, if your pattern, and I have people who, you know, I've been going once a week my whole life and I'm perfectly happy and this is fine. I say, well, fine. That's fine. There's no problem with that. Or I go after every time I eat. I have a healthy bowel. Fine. That's the way you're wired. You know, that's not a problem. So when we think about a problem is when there's a change, right? So when there's a change, you want to look at it and you want to say, okay, what is that change caused by? Was there a new drug was introduced? Are they hypothyroid? Are they on narcotics? Are they on calcium channel blockers for their blood pressure and it's decreasing their smooth muscle activity? You know, did the diet change? You know, so you have to, again, you got to be a little bit of a detective to get in there, and then hopefully you can find a simple solution. We use those red flags again for who are we going to scope, bleeding, weight loss, that type of thing. But mostly we can treat with behavioral changes. And again, there's a whole, you know, you see Linzess. So you see, you see the drugs. So there are medications out there. Again, none of them is side effect free, but there are medications that Linzess that you see advertised that increases chloride secretion in the bowel. There's a whole, you know, laxatives. People used to be afraid of laxatives, but laxatives are really pretty safe. So I don't think, you know, in the old days we had some laxatives that weren't so safe. They said you get a cathartic colon. You wind up with a bowel that will never move. Well, it's not really the case with most laxatives that are out there. So you could feel, you know, to use a laxative periodically, no big deal. All right, the diarrhea piece, so many causes, and the one that we're the most, that we rule out straight away is C. diff. That's the that's the scourge. That Clostridium difficile, the spore-forming anaerobic bacteria that takes over. It's probably always in our guts, but it takes over when you've suppressed the other bacteria. This is why you don't want to go on antibiotics. This is why you don't just take a Z-Pak for a cold. You wait. You try not to because you're afraid of C. diff, because you know it can be hard to treat. It can come under control and it can come back. And we all have nightmares about people, you know, especially older people or infirmed people. If they can't control their bowels, it's just a disaster. So my friend Gail was going to ask about the question. So I've done one fecal transplant. So that fecal transplant has been used successfully for recurrent C. diff. So this woman had it came back about 4 times, and she said, you know, my husband's been giving me shit for 40 years. He might as well give me some real good shit. so it was so funny. So they were such a cute couple, and we had to make sure he was healthy and that he didn't have it. Very often you find that this partner has it also, they're just not symptomatic. So you have to find out that he doesn't have it, and then you have to go make sure he doesn't have anything else. And then you get the lab at the hospital to mix it all up, and you do a colonoscopy, and we put his stool in her colon, and she was cured. And this is very labor intensive. So of course, people are trying to find out what's healthy gut flora. Can we just make a pill or an enema? Can't you just feed it or, you know, something? And then if this gut microbiome is so important, maybe if I have brain fog. I have this kid who says he has brain fog. Maybe I'm going to get a fecal transplant. You know, I mean, so it's out there, you know? So it's out there. And I was at a meeting where somebody said, all you have to do is Google it and you can get a kit. So I don't know about the black market on fecal transplants, but but for recurrent C. diff, it really is successful and it can be done. It's just too bad. We really just don't want to get C. diff. The irritable bowel, again, this is the brain in the gut. And the definition of irritable bowel used to be called a diagnosis of exclusion. We used to take these poor people and put them through so much testing. And now it's pretty clear that it doesn't have to be a diagnosis of exclusion. If you have, say, 3 months out of 12 months, that, you know, maybe 1/4 of the time, you have abdominal pain associated with either diarrhea or constipation, you're having no weight loss, you have no bleeding, your basic lab tests are normal, you probably have irritable bowel. We have to manage that. How we're going to manage it, we're going to try to manage it by managing, well, we're going to try to see if we can figure out anything, again, the detective work, anything behind it, medication, something you're eating, some life stress, thyroid disease, anything we can manage. And then this concept of visceral hyperalgesia, which I think is just fascinating because I think it pertains to a lot. This concept of sensory integration, and I'll get back to Ellie, maybe I'll end with that because it'll kind of wrap it up, that sensory integration dysfunction, you get information from your environment, and everybody processes it differently. So somebody needs loud music in order to think, and somebody can't think with loud music. And somebody, likes spicy food, and somebody needs bland food. And that's a spectrum of sensory processing. How we respond differently to the same stimuli has to do with our nervous system. So the same thing is in the visceral nervous system. So visceral hyperalgesia is, I've got a gal today, I'm talking to her, she can feel her esophagus. She feels her swallow. She can feel things going through her gut. This is ruining her life. How can I tamp down the messages she's getting? If I manage her bowels, maybe it'll help a little bit, make it so she doesn't get distended. Can I work on her nervous system? Can I work on her gut microbes? So again, this is a really interesting sphere, this irritable bowel with visceral hyperalgesia. I feel too much of something that I'm not supposed to feel, and there is a it gets into this thing where you're always getting information from your gut, called the visceral afferents. They're coming up your spinal cord, they're going to your brain, and a healthy brain has the ability to tamp it down. So you don't get that information. So you're not aware until your bladder's about to burst, but you don't feel every drop building up. You don't feel every bit of stool that's going through. But if for some reason, and maybe it was childhood trauma, or maybe it's the way you're wired, or maybe it's inherited trauma, which I really believe exists, you can't tamp down the feeling, then you are left with this hypersensitivity. And I think it's going to get, the idea that this chronic fatigue and fibromyalgia, that has pieces of irritable bowel, and it has pieces of this visceral hyperalgesia in it. It just makes me feel like we're going to learn more about the effect of acute stress and chronic stress on the nervous system. And I do believe it's a place where there are probably a lot of Eastern modalities that can be helpful with this concept of balancing the nervous system. Okay, so let's stop and let's get questions.
What causes the acid, and can one strengthen one's diaphragm in order to alleviate?
So the acid is being produced all the time.
Could you repeat the question, please?
What causes the acid, and can you strengthen your diaphragm to try to help keep the acid out of your chest? Is that what you're...
That's my question.
So the acid is being made all the time, and it's made in response to food, and it's a healthy thing. Healthy people make acid, okay? That's one thing. The acid has to go in the right direction. So it's not, so the diaphragm may be playing a role. You cannot strengthen your diaphragm. You can relax somehow, but that concept of pressure building up in the stomach. Well, when I have a patient who comes in with reflux, my first question is, how are your bowels? Because if they're constipated, that's pretty easy to treat, and then I can alleviate the pressure somewhat in the system and maybe get things going in the right direction. There's a book that I'm very excited about called Gut Bliss, and I recommend it to you all. And it's where the East meets the West, and the yoga, and the woman is really brilliant. And she's talking in the book a lot like I'm talking here, about using your judgment, using your diet, understanding what the diseases are. So it's a very good resource. Her name is Kahn, Chutkan. She was a professor at Georgetown and then opened her own digestive disease center or something, and wrote a book and got on Dr. Oz. But it's really very, very good, well researched, and it's good. So for that type of question, you bet, Mickey.
Regarding her, okay, about the acid. Now, the acid comes up, so you explained why. But what I don't understand is if you do the old-fashioned, take apple cider vinegar and water, you have helped it. I have done it. How could acid on acid, does that make sense?
Well, I know that it works.
You do.
So it's not just acid. Maybe there are many aspects to this reflux. Maybe bile is coming up too. I mean, this is what we can learn when we do these fancy pH studies. We can see, so, if this thing is open, all kinds of things can come up, right? Bile can come up. Maybe it's the hyperalgesia. Maybe it's the sensitivity. Maybe that apple cider vinegar is helping your motility. And so your stomach is moving better.
So the acid
I don't know. But I know that observation. Yeah, hi.
I have that question, so I'm going to limit myself to one. And as you know, I'm a therapist, and I work with a lot of adolescents. And when you're talking about the hyperalgesia, and then also a lot of times I see adolescent girls with bulimia. Is that?
Oh, it's huge.
Does that create higher risk factors, and should they be scoped or?
It's huge, but I think what it's mostly huge for is function. Wait, the question is, this person is a therapist who sees a lot of adolescent girls and may see girls with bulimia, may see girls with this hyperalgesia. So maybe they've got some underlying stress type of thing that's got them into that chronic stress thing with the hyperalgesia. But as far as the bulimia, it was shown years and years ago that in anorexia and bulimia, you get motility disorders. And I used to think of it again, like trying to make the metaphor, if you were a stomach and you were only going to see 100 calories, you would move it so slowly so you could absorb every little tiny bit, you know, and they want, and so again, that brilliant body of ours in trying to compensate for this disease state is creating a motility disorder. And they get a motility disorder, and they often have then a stomach that won't empty. And I see them with constipation and stomachs that won't empty, and they want laxatives, and they want motility drugs. And it's a real challenge taking care of these people because they don't feel well, so they won't eat. And it's a vicious cycle. You know, so the motility disorder. So as far as being scoped for Barrett's, I wouldn't, you know, you want to, you know, Barrett's is a disease typically of older white men. So I would not be introducing a fear of cancer into these girls, but I would be saying your body is supposed to function in a certain way, and when you're working it backwards, you know, it's going to keep a memory. I mean, or maybe you don't even want to do that, but we do know that they, down the road, I have them all over my practice with motility disorders, you know. And once you inquire, you find out that's part of the past.
Well, just as sort of a nice affirmation for some of the healthcare here in New Canaan, just to encourage everybody. There's a nurse you know well, Janet Reed, who works in the high school and in the middle school, and she gets this for the sake of the adolescents. She has even said to me, she refers to something as 5th grade tummy, and she said so many boys and girls, 5th, 6th grade, there's such level of anxiety, and it's not the bacteria, it's not anything, but there's the anxiety, and they truly get this tummy. So she wants them to come into your office, calm down, reduce the anxiety, they're fine, and then go back out. But
and try not to medicalize,
right,
because we don't want to create a cadre of, you know, of medicine seekers, right? Of illness-seeking behavior, as best as you can.
right.
You try to, yeah, and it's so, yeah, but that's great to be able to treat it that way, because everybody wants to take something. What can I take? What can I take, right? And we're only too good at figuring out what you can take. So you have to be very skeptical, you know, hold back on the what can I take. Go forward on the how can I understand, what can I do, anything I can change. It's a better way going forward. Yeah.
Specific, but you mentioned a line and Prilosec and that kind of thing. Like, do you think that a Prilosec is just as something like a line and probiotic is just as bad as a Prilosec, or?
Well, the only thing about a line, no, it's a totally different kettle of fish. Oh, a line Prilosec is a line. You know, I had said Prilosec, and if you need to block your acid and you need Prilosec, take Prilosec. It's better than having that ulcerated esophagus, right? It's better than having a bleeding ulcer. You're always weighing the risk-benefit. So Prilosec blocks acid well. Use it for what you need it for, and then try your best to manage your behaviors so that you'll need less and less. That's all I'll say. Or I say, okay, when you're doing well for a week, go to Pepcid. It's half as strong. And then go to Pepcid every other day. You just see what you can get away with, you know. So, you know, try to change your behaviors, try to take as little medication as possible. The probiotic is so interesting because, first of all, you can't be sure that every probiotic has living bacteria. And people have gone into health food stores and they've taken those probiotics off the shelf and they've put them on Petri dishes, and half of them don't grow. So half of them are dead, okay? Then the ones that have a little more, you know, cachet, Align, Florastor. I said, look at this. I'm walking in the Wellesley Land Trust. Look at this land. And you see the grass and the trees and the skunk cabbage, and you see all these different species. Now, if you just go in there and throw some seeds of something, that's not going to take. This is all here for a reason. This needs more sun, this needs less sun, this gets water, this is low, this is high, right? That's what your gut microbiome is like. So just throwing in a line, I don't think is going to make much difference. I don't know why it would set up shop. Unless you're depleted, unless you're completely depleted, unless you've been on a strong antibiotic and then you're going to try to replete with some kind of a mixture. You know, that's the way I think it has some use. And then you might say, well, am I just as well eating kimchi and eating yogurt as taking a probiotic and getting my healthy diet back? Maybe. These things have not been well studied. We do them, you do them, they're not well studied. Okay? That's where I see it. Yeah.
Can gallbladder surgery affect the gut adversely, gut behavior?
Well, the gallbladder stores bile, right? Can gallbladder surgery affect the gut adversely? So the gallbladder stores bile, which is made by the liver and is used to digest food. And when you eat food, a hormone is released from the stomach, and it says, gallbladder, contract and send me some bile because I'm sending you some food and we want to mix and digest and absorb. So when you have removed that gallbladder, then that bile is just dripping out all the time. So you have a little problem in mixing with digestion. About 5% of people have their gallbladder out. The bile will irritate the colon and cause some looser bowels, cause some water secretion into the bowel. So post-cholecystectomy diarrhea is 5% of the time. Probably more common than that, and then it becomes less and less. Otherwise, that's pretty much it. As long as you don't have a complication from surgery or a stone left in the bile duct. You know, we see all of that. It's such common surgery. It's done so often and typically so well. So that's it. Yeah.
Is collagenous sprue the same as celiac disease, or is it a form of celiac disease?
Collagenous sprue is a term that's used for celiac disease that doesn't that is persisting after you've removed the gluten. I think, yeah, because there's not collagen. There's something called collagenous colitis, and there's atypical sprue. There's collagenous colitis affects the bowel, but there's no collagen in celiac disease. There's no collagen that lines the bowel in celiac disease. So this may be part of something to describe celiac disease that is, maybe it's celiac plus.
Celiac plus?
Yeah, I mean, I've had people who are gluten-free and still symptomatic from celiac, and we wind up having to use immune suppressants. And so they've got a disease that goes on beyond, you know, the immune reaction doesn't quiet down just by removing the gluten. And we're looking for every other reason. Celiac can affect some other organs. But
so if you have celiac and you have no symptoms, do you need any further endoscopies, or you
No.
just don't?
No.
No.
Yes?
Is there any data available that would help to inform the public and the medical field as to what percentage of the causes of all these gastrointestinal disorders or diseases are physiological versus those that are psychological?
what percentage of all of the diseases of the GI tract are physiologic and which part are psychological?
Are caused by physiological factors or by versus psychological factors? In other words,
Well, I use that phrase, alarm symptoms, bleeding, weight loss, poor appetite, abnormal lab values. You know, all of that bespeaks
physiological.
over the ledge, as I called it. You're in disease state. You're not imbalanced. But at any point in time, I believe that there are psychologic aspects to every place along that spectrum, to the balance and to the imbalance. So I think the psyche plays a major role in healing at every point along the spectrum.
a condition, diastasis.
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 Diastasis of the rectus muscle.
Yeah, is that logically caused by a stretch?
I don't think so. I think that's, so yeah, got the six pack, right? It's just this, your rectus abdominis muscles. And in the middle is a band of tissue that's not muscular. And if that band separates, it's called a diastasis. And it's not an actual hernia. But if you do a sit-up, you can see the abdomen coming out like this. So I don't, so your question, is it caused by?
A stretching of the muscle tissue. Is that logically
Well, these muscles contract like this. And we're talking about an increase in the space between them. So I think it's probably, it probably could be caused by increasing your abdominal girth, like somebody who got very heavy very quickly, but I don't see it. I see it and I don't see it in heavy people necessarily. I bet it's more about just the luck of the draw. I would bet it's about how you are formed, how much muscle is there, and how much collagen. That's avascular, that center, and just having more of that center relative to the amount of muscle you have. I bet it's sort of something about, I don't, it's sort of more of a surgical question. So I shouldn't say I know, I don't really know. I remember, somebody who wanted surgery for a diastasis. I remember having a hard time getting a surgeon to go along with it. It's sort of more of a cosmetic thing, right? I mean, I don't think it can cause any damage. Yeah.
I have a question. Moving out of Western medicine for a minute, can you speak to irritable, not just irritable bowel syndrome, but the leaky gut?
The leaky gut
and
concept?
Well, and how it affects all this or prevents all this, and whether or not you agree that keeping your gut free controls the Alzheimer's later on.
Oh.
Can you speak to that, or do you have no?
No, I have my own sort of
Yeah.
concept about the leaky gut, my own concept that I've constructed in order to make sense of it. But it does, you want to hear that?
Yes.
It's a secret. It's just, it's like how you make sense of something that you hear all over the place, and how there must be something to it, but I don't, it's probably not everything, and is it probably, so the way I think about it, again, back to the nervous system, I think that the motility is, what manages the, I said there are 10 times more cells in your microbiome than in your whole body, and what manages those populations of cells is the motility of your gut. So you have the sweeping motion that's always getting rid of bacteria. Your stool is 90% bacteria and a little bit of fiber and a little bit of water, So you're always getting rid of this microbiome, and it always has to repopulate. And if you have stagnation from stress, constipation, anxiety, or some illness, you have stagnation, then you get bacterial overgrowth. And we know the condition of bacterial overgrowth. Bacterial overgrowth actually creates inflammation. And inflammation actually breaks down cell walls. So that's the way I can merge my Western mind to this concept of leaky gut, to say that the motility underlies the bacterial population, which underlies the health of the gut wall. And then once you've got that gut wall breakdown and inflammation in the gut, then you're getting stuff through, and that's why you feel better without certain foods that would have rapid access to your bloodstream and to your brain. I mean, that's the way I can think of it.
Do you test for that, and do you use L-glutamine for treatment, or you're
What
not
kind of a
into that?
test would you use?
Intestinal permeability studies, do you do that?
No.
Okay. Do you treat with L-glutamine? Do you recommend that?
No.
Okay, well, all right.
Yeah.
What happens when your saliva turns sour right after you eat something sweet?
What happens?
Your saliva turns sour after you eat something sweet. I think that's probably acid reflux. I mean, sour is acid, and acid comes up into your mouth. People call it water brash or something. So I don't know if the sweet provokes the acid reflux, But if you've got a sour taste in your mouth,
But you don't feel anything coming up. It
Yeah,
just
right.
feels sour.
right, you have a good esophagus that doesn't feel it. You just taste it. You know the answer, don't eat the sweet thing. Yeah.
If whenever you've had a periodic colonoscopy, they've come up with pre-polyps and 3 or 4 or 5, is this an indication that you may be susceptible to cancer?
Absolutely.
Somewhere else in your
No.
body?
No, I don't think so. I don't think so. I mean, there are cancer syndromes where families have multiple cancers, but that, no, that's an indication that you may be at risk of colon cancer.
Yeah.
Not.
But it's not an indication that.
No. Yeah.
Hi, what do you think about a teenage patient that presents with symptoms similar to celiac, but has a negative blood test for the screening test for celiac? What are the next steps in a teenage?
Well, you could do a cheek swab and do a DNA test. Oh, if somebody tests a teenager, you're not so anxious to put a scope in them. You think they may have celiac, your blood test is negative. You have about a 5 to 10% chance that they still have celiac. So the only thing you have is you have a cheek swab. If the cheek swab showed they didn't have any of the DNA markers for celiac, then you'd be pretty happy to say there's no celiac. You could, otherwise there's a small bowel biopsy. The cheek swab is the genes, the antibodies are the reaction, and then the small bowel biopsy is the effect on the tissues. So that's what you have. I guess, there's some other subtle things you could check: stool for protein wasting. I mean, you could check all kinds of blood work to see is that person really, if they were anemic or, if they...
Persistent diarrhea, though.
Persistent diarrhea and the celiac blood work is negative. Well, I would like to do the whole detective thing, I do and then there's something that goes along with celiac called microscopic colitis. I thought you were talking about that with the collagen, the sprue, but microscopic colitis, so you could give her Pepto-Bismol tablets. That will help, that will clue you into microscopic colitis, if it works. If it works, and don't worry because it turns the stool black. Don't worry. But that's what you got. We have a resource. We have this Peter Green, who's at Columbia, who's a world expert on celiac disease. And so he's at Columbia, so if you have any questions about celiac, you can see him, or he's got a dietitian who just works with him. They've got a whole center there that's, to help you, but probably he would put her to sleep and do a scope. But I get it, you just want to rule out everything else first. Okay, Kathy. Hi.
Hi, sir. Could a silent indicator of GERDs be a change in dentistry? Like, you go to the dentist, you have great hygiene, and all of a sudden, boom, they're telling you you have 15 cavities.
Absolutely.
Okay, and then how do you treat for as asymptomatic GERDs? Especially when you're practicing see somebody under 18. You don't want to pop pills.
You don't want to pop pills. If a young person has that degree of reflux, there are tests, where you can put down a probe and you can measure acid over 3 days and see if they indeed have reflux. I mean, you can answer the question, do they have reflux? You could answer that question with a scope, put down what's called a Bravo capsule, and then walk around for a couple of days, and again, you get a recording of how often is that lower part of the esophagus seeing acid. So you could get that answer a little bit invasively. And I think there's a guy in Greenwich who everybody is very excited about, a pediatric GI guy who comes down from Yale. So that's a little tough. And in 6 weeks of acid blockers, you're not going to know.
Right.
You're not going to know. But I think that's probably important enough because I think that might be important enough to scope and do that Bravo capsule. You really want that answer. After you check the room for the M&Ms under the pillow. Yeah.
Would you repeat the name of that book that you're excited about?
Oh, Gut Bliss.
Gut Bliss.
Yeah. Okay? Done? Done. Thank you.